who's going to provide an update on the management of kidney problems for patients with COVID-19.
Hello, I'm Claire Sharp and I'm a consultant nephrologist at King's College Hospital, and I'm grateful for this opportunity to talk about the management of kidney problems in patients with COVID-19. I'm going to focus on acute kidney injury, primarily in the intensive care setting, as this is where we have had the most challenges. As I was preparing for this talk, I was surprised to look back and see what a short period of time has actually passed between the beginning of this crisis and now, as we feel we are hopefully over the worst of it. During the early days of the pandemic in the UK, between the 28th of February, when we were told the first person-to-person transmission had occurred in the UK, and the 5th of March, when the first death was announced, as a nephrologist, I was mainly concerned for our vulnerable dialysis and transplant patients and how this would impact upon them. None of the early reports coming out of China suggested that acute kidney injury was a significant feature of the disease, and subsequently there have been many papers, such as this one from Wuhan on 116 patients, which have suggested that AKI was not a cause for concern. Perhaps more informative, though, is this paper, which has also come out of Wuhan, reporting during a similar time period to the previous paper, but with a bigger cohort of 701 patients. AKI, although not completely absent in this group, was still not common in the cohort as a whole, only occurring in 5.1% of patients. 113 of these patients died, and what can be seen clearly from this graph is that those patients with AKI had a much higher cumulative death rate, reaching approximately 75%. These data tell us that although AKI was not a common finding in patients admitted with COVID-19 in Wuhan, it was a very poor prognostic sign. Unfortunately, we now have plenty of UK information to inform us of how this disease has affected our own population. To date, over 180,000 people have tested positive and over 28,000 of those have died. Although many people are frantically collecting data, we don't yet know what the overall rate of AKI is in everyone admitted to hospital. But since mid-March, the Intensive Care National Audit and Research Centre have been collecting data on all patients admitted to ICU with COVID-19 across England, Wales and Northern Ireland, and reporting this back on a weekly basis. I've used data from these reports to draw this graph, which shows how many patients in ICU with full completed outcomes, so this includes only those patients who have left ICU or died, who developed acute kidney injury requiring some form of renal replacement therapy. You can see from these data that approximately 20% of ICU admissions have required renal support, but this has actually varied hugely across the country, with some units reporting less than 5%, while others have had as high as 75%. Having listened to the information coming out of China, this large number of cases of AKI wasn't anticipated, and so it wasn't until mid to late March, when the reports started coming through, that we realised we were going to have to facilitate much more renal replacement therapy on ICU than we had planned for. At the same time, a similar pattern of high levels of AKI on ICU was being reported in the US, and it became quickly apparent that the high demand for both machines and consumables needed to provide renal replacement on ICU was going to challenge the national and indeed international supply line. Whilst we had plenty of warning that we would need to increase the availability of ventilators to cope with the pandemic, we hadn't anticipated the demand for hemofiltration machines, and so we were not prepared. So why is it that there has been such a high rate of AKI in COVID-19 patients in the UK and the US, and probably also in the rest of Europe? Well, it's definitely multifactorial. But firstly, by the time these patients arrive in ICU, they are often extremely dehydrated, following several days of very high temperatures and not eating or drinking. Initially, it was felt that patients with COVID-19 pneumonia were developing ARDS early, and the advice was to run them dry, to prevent worsening of their lung inflammation. So intensivists were avoiding aggressive fluid resuscitation, which probably exacerbated some early onset acute kidney injury. As we developed more experience and data were being released, it became apparent that these patients weren't behaving like typical ARDS and that dehydration was causing high rates of AKI. So NHS England revised its guidelines on the management of patients outside of intensive care unit to encourage clinicians to rehydrate patients with evidence of fluid depletion in an attempt to minimise the number of patients with AKI requiring renal replacement therapy on ICU. Dehydration alone, however, is not the only reason why these patients are developing AKI. As you know, it is felt that patients who develop severe COVID-19 may do so as a result of a cytokine release syndrome, or cytokine storm, a severe systemic immune response to the virus. This has been well described in previous outbreaks of SARS and MERS, and this cytokine storm is known to impact on renal function and may well explain some of the renal pathology we are now seeing. Hypercoagulation is another phenomenon that has become a real issue in these patients. Many are being diagnosed with pulmonary emboli, and although we aren't doing renal biopsies in these patients, it's quite possible that microthrombi are impacting on the renal circulation. This hypercoagulation also compounded the crisis in supplies of hemofiltration consumables, as patients were clotting their filters frequently, needing the sets to be changed. There is also emerging evidence that the SARS-CoV-2 virus can directly target the kidney. This paper by Su et al. Has reported on 26 postmortems of patients who have died in China with COVID-19. It demonstrates not only that red blood cell aggregates in the peritubular capillaries, suggestive of sludging of the microcirculation, but it also shows virus particles infecting tubular cells and podocytes. Finally, one factor that may account for the discrepancy between rates of AKI in China compared to the UK and the US is ethnic variation. Again, looking at the most recent ICNARC data on patients admitted to ICU with COVID-19, we can see that patients of Asian and Black ethnicity make up 25% of these patients, compared to only 8.5% of patients admitted to ICU with non-COVID-19 viral pneumonia between 2017 and 2019. When we look at the rates of AKI in patients with COVID-19 by ethnicity, we can see that Asian patients and Black patients are more likely to need renal replacement therapy than Caucasian patients. On the 15th of April, NHS England published guidance which stated that in all cases, maximum medical management should be considered before attempting renal replacement therapy, including the use of loop diuretics for fluid overload, potassium binders for hyperkalemia, and sodium bicarbonate for the control of acidosis, in an attempt to reduce the use of renal replacement therapy. In that document, they also listed the various forms of renal replacement therapy which can be used, depending upon the expertise and resources available. The three acronyms highlighted in yellow in the left-hand column stand for continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, and continuous veno-venous hemodiafiltration, which are the most common forms of renal replacement therapy used in intensive care. The middle column refers to forms of hemodialysis which are more commonly delivered to patients with end-stage kidney disease and which require specialist infrastructure in place to provide ultra-pure water if it's going to be delivered in the intensive care unit. And the right-hand column describes a low-tech form of renal replacement therapy called peritoneal dialysis, which is used relatively commonly in patients with end-stage disease, but rarely in patients with AKI. At King's College Hospital, we have expertise in peritoneal dialysis in end-stage kidney disease patients, and we have also used it intermittently in patients with acute kidney injury, though very rarely in ICU. We had one of the highest rates of acute kidney injury in the country, and when we became aware that there was going to be a shortage of filtration machines in ICU, we decided to turn to peritoneal dialysis. The tubes are inserted into the peritoneal cavity by a trained operator under local anaesthetic, and fluid of varying osmolarity is drained into the cavity and left to dwell for a period of time before being drained out and replaced with fresh fluid. Fluid is effectively removed from the patient by convection generated by the osmotic gradient between plasma in the blood vessels running through the peritoneal membrane and the dialysate, whilst small molecules are removed through diffusion down a concentration gradient. Here you can see some data on our first 30 patients with COVID-19 receiving automated peritoneal dialysis for AKI between the 31st of March and the 26th of April, demonstrating its utility in controlling hyperkalemia and acidosis. Although 8 of these patients have now recovered renal function, unfortunately the early signs from China, albeit only a few patients, have also been shown to be true in the UK, as approximately 75% of patients who have required any form of renal replacement therapy have died in ICU. The most recent report from ICNARC was released last Friday, the 1st of May. It shows us that new admissions to ICU are decreasing day by day, and this is now resulting in falling numbers of patients requiring renal replacement therapy. So hopefully this initial crisis in RRT is coming under control. Many thanks for listening. I'll finish there, but with an acknowledgement to Elaine Bowes and Hugh Cairns, who run the PD service at King's College Hospital and who are the driving force behind the ICU PD service.